Is it playing? I don't hear it.
I don't hear the music either. That's all right. Try hitting the enter button.
Okay.
Anything?
No, the PowerPoint isn't advancing. I'll be right over, Paul.
Can you advance it back one, Paul, or does it just go forward?
Yeah, I can go back.
Okay. Are we waiting for the music, or you want to get started?
Melissa's on her way over.
Okay.
Okay, I'm just gonna push it forward. We didn't get the music, but that's okay.
That's great. Perfect. Pretty good one.
Okay.
Go ahead, Neil. Did you want to do the
Great.
introduction?
Yeah, thank you everybody for joining us. A few technical difficulties before we get going, or before we got going. Thank you for joining us for this live presentation brought to you by the Law Offices of Melissa Day. I'm Neil Diegelman. I'm an associate with the Law Offices of Melissa A. Day. Our presenter today will be Paul Kornacki. Paul is an experienced workers' compensation attorney who has been practicing for many years and has been with the LOMAD office for just over a year now. And I can tell you that over the 6+ years that I've been doing workers' compensation, I've known Paul, and you can always go to Paul for questions and he'll generally have the answers. So this is going to be a great presentation today. Your microphones will be muted during the presentation portion, and we'll unmute at the end if there's any questions. And thank you for joining us for Lawyers and Friends.
Thank you so much for that wonderful introduction, Neil. And today we're going to be discussing the 2021 medical treatment guidelines for hip and groin injuries. The board has introduced a series of brand new medical treatment guidelines, which I know are going to be very helpful. I think it's going to be interesting because it's going to provide guidance for medical providers, for carriers, and for claimants with respect to these new conditions. Let's just go back for 1 second and remember what the purpose of the medical treatment guidelines are. They're supposed to create a standard of care for injured workers. They're supposed to help expedite quality care, supposed to improve outcomes, and in theory, they're going to reduce disputes between carriers and claimants. If the medical provider wants to provide a different treatment from the medical treatment guidelines or a repeat treatment, then a variance has to be submitted. So let's start at the very beginning of the brand new hip and groin guidelines with Section A. Neil, how are you? Can you hear me okay?
Yeah, Section A is pretty standard from what we've seen from the 2014 medical treatment guidelines, and is actually exactly the same throughout the new 2021 medical treatment guidelines. In prior presentations of Lawyers and Friends, we had mentioned the new, there's 2 new sections in Section A, which I think they're repeating. A6 has been added to the 2021 medical treatment guideline for the hip and groin, and all of them for that matter, about acuity, which breaks down to acute, subacute, and chronic. So that's acute, less than 1 month, subacute, 1 to 3 months, and chronic is greater than 3 months. And I think it's good that they explained those differences and they use them throughout the guidelines for types of diagnostic treatments and medications and things of that nature. In Section A, they also added A7, which is initial evaluation. And under there, it just kind of, it's a small little paragraph, and it just gives the acute time frame following the injury, and it's not used to define when a given physician first evaluates an injured worker in an office clinical setting. So there's two new additions to the general guideline principles in this section. For me, preparing for today's presentation, I found it very helpful to go back and actually read all of the general guideline principles, because we sometimes as attorneys will throw the words of positive patient response, and we're used to using that in our arguments. However, I found it useful to actually just go back and reiterate that it's objective functional gains, positional tolerances, range of motion, things of that nature. And just, it's good to refresh your memory about the guidelines, because when before the 2021 came out, I would say the 2014, we go to specific sections, what we're looking for. And for myself, I can say I would sometimes not really go over the guideline principles. So as a practice point, I think as attorneys, we should all, and claim professionals, go over that section again, see if there's anything that we forgot about or want to freshen up on, for sure.
And also for Section A, they do provide some guidance regarding the initial evaluation, some diagnostic timeframes, treatment timeframes, and all the various interventions that are discussed throughout these guidelines. And remembering that the interventions that are approved and are authorized are designed to get the injured worker back to work. So why don't we start with the initial Section B, hip and groin disorders, and acknowledge that when someone comes to a doctor's office, I fell off a ladder, I've got severe hip pain. There are certain red flags that the provider should be looking at, and there can be other possible explanations for the hip pain. And the new guidelines point out that providers have to be aware that another possible explanation could be a tumor, which would result in severe localized pain. It could be infection in the hip, which was just triggered by a traumatic event. It could be a neurologic deficit in the spine itself, and not a true hip injury, among other things.
So in Section B, it also talks about history taking and physical examination. And for myself, again, as a practice point, I found it great it says that the history of the injury, should be reasonably documented, and it goes through the mechanism of injury, relationship to work, ability to perform job duties and activities of daily living, exacerbating and alleviating factors. This is all great information, or great questions that we should be asking doctors on a deposition. And if they don't document this properly, we should bring it to the attention of the judge to help prove the point that we're trying to make.
Thank you, Neil. Regarding the initial testing for hip injuries, typically the guidelines indicate that a simple, oftentimes just a simple diagnostic test will provide enough information to form an initial diagnosis. But they do go on to suggest that additional repeat testing or different forms of testing may be necessary where there is a progression of symptoms. Also, additional testing or imaging studies are going to be needed after, if there's any kind of surgical intervention to follow the healing process. So typically, the initial history given by the claimant along with the initial diagnostic testing will assist in forming the possible diagnosis of hip osteoarthrosis or hip dislocation, hip fracture, labral tears, and there are various other groin strains that are noted throughout these medical treatment guidelines. Neil, did you have any other observations?
Yeah, so in I still was fascinated with the section B2 with taking the history and kind of, with that being said, they listed, some past history that you'd want to know about. And this is the first time, not the first time, I didn't know what neoplasm was. So I had to look that up, and that is abnormal growth of cells, which is included like in the past history. So if there's a history of neoplasm. Also barotrauma, which is caused by a difference in pressure in the body versus outside, but I've never heard it called barotrauma, which is interesting. Physical examination, I thought was interesting, and it is mentioned further in the medical treatment guidelines that we're discussing, but examining the hip joint is one part of it. You should also examine the knee, the abdomen, and we'll get into that a little bit later, I'm sure, but I found that interesting. So when we get an initial report from a doctor for a hip injury, and it's showing that they examined the knee, the abdomen, the back, we might be like, whoa, that's totally not acceptable. We should be objecting to that. But I don't think we really would be unless it was a continued type of examination and treatment to the unrelated sites. But I found that interesting for that section. Thank you.
Thank you, Neil. Which brings us to probably the one of the more common hip injuries. That's osteoarthrosis. It's the same thing as osteoarthritis, only there is less inflammation. And regarding the initial testing for hip osteoarthrosis, the guidelines do provide us with a number of accepted studies that can provide us with that diagnosis. The first is antibody testing, and there are numerous forms of antibody testing which can provide an initial diagnosis of osteoarthrosis. They also recommend a bone scan, as well as a CT scan, but is not recommended for routine diagnosis. Probably the gold standard of testing for osteoarthrosis is the MRI, as well as X-rays.
I like how in these guidelines for the MRI, for the testing, it actually says that the MRI is considered the gold standard. I thought that was a pretty interesting point that they wanted to make out. And the guidelines also here and in other sections that discuss a CT scan is recommended for patients who can't have an MRI, and other recommendations, but that's one that stood out for me. So if there's a contradiction for having an MRI, no problem.
Approved treatments for osteoarthrosis, and I suppose the first initial treatment would consist of medications. The guidelines do indicate that NSAIDs are the front line and are actually considered as effective as opioid medications, which I thought was very interesting. People with bleeding disorders, though, acetaminophen is also recommended. But again, as far as medications go, it's NSAIDs are the first order. Opioids can be authorized or approved following surgery, but only for a very limited period of time. Neil, did you have any additional comments on medications?
So the outline of these guidelines are they mirror each other with the introduction to diagnostic study, medications, treatment, injection therapy, surgery. So with the medications, as this is the first one we're getting into, I found it interesting where they said acetaminophen is modestly less effective. So they're saying that it's less effective, not saying it's not recommended, which I found interesting. I also found it interesting that they gave consideration for people who have gastrointestinal issues and provided other types of medications that can be taken in combination there too, such as hormone medicines or antacids by prescription. So I found that pretty interesting. The opioids, I was happy to see, was limited to a duration, 1 week maximum, and from there, I mean, they would have to obviously file the MG too, so.
And they go on to discuss treatments for osteoarthrosis, including hot and cold therapy. But I think the main treatment recommendation, at least at the beginning, is some kind of rehabilitation which would include physical therapy or occupational therapy. They do indicate that this can be a significant amount of physical therapy, up to 12 to 15 visits initially, with additional beyond that if the claimant remains symptomatic. They do indicate that acupuncture is an acceptable treatment, which I thought was interesting. There are some injection therapies which can be utilized.
Sorry, Paul.
Go ahead, Neil.
Melissa, can you hear him? Am I the only one?
I can hear him.
Okay. Are we still there?
I read you loud and clear.
Thank you, James.
Okay.
As I was saying, if rehabilitation is unsuccessful, the medical treatment guidelines discuss various injection therapies. Following that, I suppose, and if all else fails, then surgery is an approved treatment, which would include arthroplasty, which is followed by an preoperative, or actually preoperative exercises are recommended first, followed by postoperative exercises after total hip replacement. Neil, are you still with us?
Yes, I'm sorry. I don't know. I turned it off and on. So you said that there was the total or the hip arthroplasty, right?
Correct.
So what's interesting to me is that on the list of surgical procedures that still require a C4 auth, you see a total knee replacement, right? But we don't see anything with regard to this hip arthroplasty, and I found that kind of interesting.
Thank you, Neil. The second diagnosis that is discussed by the medical treatment guidelines is osteonecrosis, also known as bone death. I find it interesting that the example given by the guidelines, they indicate underwater divers who utilize compressed air and sometimes have to rise to the surface unexpectedly. Results in a lot of nitrogen in their hip. I can't remember the last time, Neil, I don't know if you have, but I can't remember the last time I had an injured worker who was a professional underwater diver who ended up with necrosis in his hip. Have you had a case recently, anything like that, Neil?
Paul, I can tell you not even recently in my career, I have not. And I thought to myself, what an interesting specific type of injury to put in the guidelines. So I did literally a quick Westlaw research, very quick, just type this in, and it only produced 107 cases. So I don't think that this is a very common occupational problem with atmospheric compression and decompression changes. But I mean, I'm sure you're going to note this. I mean, the other one is major trauma.
Probably a much more common cause of osteonecrosis would be major trauma, which we do see commonly in complex falls where there are severe hip injuries. Again, they provide where there's a diagnosis of osteonecrosis, they do provide the standard diagnostic studies that are approved for this diagnosis. A bone scan is one of those. A CT scan is recommended. There are various forms of CT scan, but also in general, the MRI and X-rays are the most common and the most utilized in forming this diagnosis. They do not recommend ultrasound. The treatments for osteonecrosis include medications. And again, NSAIDs are the most common form and are approved, but the acetaminophen, and they do indicate opioids, but again, only a maximum of 1 week of opioid medications. Neil, did you have any other comments about osteonecrosis?
Well, I think that some of the treatment is interesting. So it says, for other treatments, it says non-weight-bearing activities is not recommended. So that's interesting. And then the go-to would be the hyperbaric oxygen to help treat with that. And of course, it says avoid being exposed, again, if it's a type of decompression compression situation. And that's what I have is interesting in this section.
Okay. Then we're just going to move along to, again, probably a much more common area of hip fractures. The guidelines note that hip fractures are common in falls, as well as in motor vehicle accidents. These also include, which I found interesting, was stress fractures, which can occur as an occupational disease as opposed to a traumatic injury.
And the stress fractures involve repeated applications of unaccustomed force over a relatively short interval of hours to days, is how they told us what a stress fracture is. The
accepted diagnostic studies for hip fractures include everything except ultrasound. The same medications as previously discussed are approved. Again, the treatments include hot and cold therapy, but probably the more common treatment for hip fracture would be surgery, depending on the exact location of the fracture itself. Neil, did you have any other comments on hip fractures?
It was interesting to see that well, I'm not a doctor, but the bisphosphonate, which is a medication that stops bone loss, is useful in this type of, with hip fractures, as it was not recommended in the osteonecrosis, which, I mean, I'm not a doctor, but with osteonecrosis, I think you would also want to stop bone loss. So that kind of stood out to me.
And the other surgeries recommended include a half hip joint replacement as well as a full hip joint replacement. So either one of those could be recommended to a claimant and could be an approved treatment for a hip fracture. Moving on now to VTEC, which is a high-risk complication in a post-operative full hip replacement or knee arthroplasty, which is an extremely serious infection. The guidelines indicate that this is a high-risk complication where there has been total hip replacement surgery. The medications that they discussed include heparin, which we've seen is a common, whether blood clotting, or warfarin, which is those two are recommended. They also indicate, oddly enough, that aspirin is a recommended medication for this type of problem. Neil, did you have any other notations on the medications or treatment for this condition?
On the medications, I looked up factor XA inhibitors, which is a type of anticoagulant that works by selectively and reversibly blocking the activity of clotting, preventing a clot. So it sounds like it works. It has the same results maybe of heparin, but you know, it's a different type of drug as warfarin, which is a blood thinner. I had never heard of factor X inhibitors until I read that.
Also among the recommended treatments would be compression stockings and low extremity pumps.
And the lower extremity pumps are for post-operative, I believe, which I found, which makes sense. I mean, I would imagine that a lower pump or lower extremity pump is more costly than just the compression stockings.
All right, let's move along to pre and post operative rehabilitation, including hip arthroplasty and hip fractures. Again, and they do indicate that this may be a slight overlap, but they do discuss the approved therapies post-operative for either arthroplasty or a fracture. This would include, and what is recommended are post-operative physical therapy and rehabilitation programs. Neil, did you have any other comments on section C5?
Just to note that when these guidelines talk about therapy as a treatment, it really is, it appears to be kind of a cut and paste for each section. There's really not too much difference. These guidelines, they differentiate between the active and passive therapy, which active obviously requires the patient to perform an internal effort, as opposed to the passive, which doesn't. And the guidelines emphasize on active interventions over passive interventions throughout the guidelines.
And next, I want to briefly discuss a fairly common injury regarding lateral tears. This is section C6. Lateral tears are generally caused by trauma. There's no fracture involved, but they can be extremely debilitating, and they do require a fair amount of treatment. They discuss lateral tears. The labrum is a soft cartilage ring lining in the hip socket, where there's a trauma to that area. It results in a tear. It can result from repetitive use, but is much more commonly seen in traumatic type injuries. The diagnostic studies to show a lateral tear, oddly, one of the recommended treatments is ultrasound. And typically, it can be seen on an MRI, but a more common diagnostic study for this problem is the MR arthrogram, which is they inject dye into it and it shows the exact location of the tear. Regarding medications, again, the usual recommendations are NSAIDs. They really don't recommend, I don't believe there's a recommendation here for opioids, not for lateral tears, or only if there's a surgical option involved, and then only for a week or so. The treatment recommendations, again, typically include physical therapy or occupational therapy, up to 15 visits where indicated. They do also recommend that hip injections, especially if they're specifically aimed at where the tear is, can result in improvement. They do recommend the use of cane and crutches where necessary. Neil, did you have any additional comments on the issue of lateral tears?
I just think it's interesting. So here I looked at the injection a little bit more closely because in the other sections where they do provide for injections, there's more types available, where here it's only the local, oh boy, glucocorticoid corticosteroid injection. And that is, it says for treatment of hip impingement or labral tears in select patients. I'm curious, select patients, I mean, because the doctor would have to provide something more other than saying, well, this patient has a labral tear, therefore we're going to do it. And obviously they'd go through the medical treatment guidelines with the indications, but I just think it's interesting that they just leave it kind of in select patients, a lofty term.
I think the main treatment for labral tears has been fairly vigorous physical therapy, and if that ultimately fails, then they do recommend surgical interventions. But again, that's a very debilitating problem, and labral tears are common where there has been traumatic injuries. They really have to be considered. It will feel like a fracture, but it isn't, and it can be seen on an MRI. The rotator cuff of the hip, section C7. Gluteus medius tendonitis or tears. This is where the bursa becomes irritated, secondary to a partial or a complete tear. Typically, again, this will require the use of an MRI arthrogram as opposed to a straight MRI. And in this case, ultrasound is also a recommended diagnostic test for this. Again, regarding medications to treat this diagnosis, they do recommend NSAIDs as a first and foremost, followed by acetaminophen, and once again, aspirin. Neil, did you have any comments on the treatment section for rotator cuff of the hip tear?
So in this section, you'll see that opioids are not recommended for gluteus medius tendonitis, or tears of trochanteric bursitis or greater trochanteric pain. But it does say that it is recommended for select treatment in patients with postoperative gluteus medius tendonitis or tear, trochanteric bursitis, and greater trochanteric pain. So that's interesting because it's not a flat out no, it's just a no, but if you have the changes, then it is recommended for there. The surgery was, so again, this kind of goes throughout the guidelines, but it's goes through in this part of the guidelines. It says that tears of the gluteus medius tendon with accompanying pain and or functional deficits felt amendable to surgical treatment. That's another one that I like, okay. But it does go on to say generally 3 weeks of non-operative treatment is advisable. So that's something else that we would be looking for when the surgery is performed, and if it didn't follow the medical treatment guidelines, file the appropriate denials. But we would want to see at least 3 weeks of non-operative treatment.
Neil, can you just repeat what you said about the surgical intervention? I didn't quite get that.
Yeah, sure. So tears of the gluteus medius tendon with accompanying pain and or functional deficits felt amendable to surgical treatment, which I find interesting. It's just amendable to surgical treatment. And then went on to say generally at least 3 weeks of non-operative treatment is advisable to ascertain whether the function and pain will sufficiently recover without the need for surgery. To me, that just sounds like a softball in a sense that, of course, we're going to try that. But if you don't see that type of prior treatment, I think that could raise an issue that we'd want to be aware of.
Thank you for that, Neil. Hamstring and hip flexor strains. I think now we're getting more into the area of groin strain as opposed to distinct hip injury. These are common. These are not really traumatic hip injuries. You might see this sort of a problem where there's in heavy duty work, where there's heavy lifting. It's more of a muscular strain. but it can involve a complete rupture of the hamstring itself. Which typically would require a surgical repair. The general tests for this type of problem are typically not necessary. Medications, and again, they recommend NSAIDs, hot and cold, ACE reps, and work limitations. They also recommend physical therapy for this kind of a problem. There are only 2 diagnostic studies that they recommend. It's ultrasound or an MRI. Again, treatment would include hot and cold therapy, physical therapy, occupational therapy. There are some injections that can help with this situation. Surgery as a last result with when physical therapy totally fails. Neil, did you have any comment on the type of surgeries that were utilized in the treatment of hamstring and hip flexor strains?
Just for larger complete hamstring or hip flexor strains. It's interesting, the bed rest is not recommended.
And why would that be? Neil? Why wouldn't rest?
I'll tell you what, I thought the same thing. So I clicked on the digital version of the medical treatment guidelines. You can click on the portion below where it says evidence for bed rest for treatment of hamstring or hip flexors, and you click on it, and it just tells you how the board came to that conclusion, but it doesn't tell you like the rationale. It just says the articles they reviewed, the number of articles they reviewed, what articles they reviewed. That's it. It doesn't say why.
All right.
I would like to take a deposition testimony of a doctor and slip that one in. Hey, doctor, why isn't bed rest recommended?
This is James. I did run across a hamstring rupture where typically if they rupture at either end, they tear the bone off because the hamstring is so strong that it will actually, rather than the hamstring itself break, it tears off the insertion point in the bone. And my recollection from the testimony in that case was that hamstrings tend to shrink very rapidly because of the tension they're under. So that they don't want people staying still because the hamstring will shrink and tighten up. And that's also why the surgery has to happen very quickly as well. Otherwise, getting the hamstring back together is very difficult.
Okay. Get some physical therapy. If that doesn't work, get the surgery. Do not rest.
That's right.
We're going to go to section C9, which discusses true groin strains, which involves the abductor muscles in the upper thigh. Again, the diagnostic studies here are the medical treatment guidelines suggest only ultrasound, X-rays, or an MRI. No other testing is recommended. Medications, there's no mention of opioids in this case, or muscle relaxants, which are not recommended. Generally, with the treatment of groin strains, there's NSAIDs, aspirin, acetaminophen. The treatment for these are typical, again, hot and cold therapies, physical therapy, which can be limited in this case to 2 or 3 visits, or as much as 12 to 15 visits. And again, the guidance indicate no bed rest. Neil, did you have any other comments on the section C9 for groin strains?
Yeah, just why did they not? So if opioids aren't recommended, why didn't they write not recommended in this section? Or is it because doctors just don't prescribe opioid medication for this type of injury? You know, like in the other there's the other section just previous in C7 that didn't recommend it, and it says it, but here it just totally omits it. So I think that's worth pointing out. Maybe doctors just don't prescribe them, so they didn't feel the need to put it in to not that it's not recommended for opioid medication.
I like the that the guidelines are that they are mentioning, specifically that opioids are not recommended. And I mean, I think that gives us the opportunity to make sure that we're resisting prescriptions for opioids at the earliest possible point in the treatment protocols.
And they specifically said NSAIDs are just as effective and far less dangerous. Just from personal experience, a groin strain can last for weeks and months, and it can be debilitating.
We'll have to hear that story someday there, Paul.
You know,
Just in a less public setting.
the pain goes away, but as soon as you try to exercise at all, it comes right back. Just when you think everything's fine, as soon as you try to get some exercise, it comes right back, and you got it. It's going to take weeks and weeks longer to get through.
Wow.
Okay, and Neil, just for now, we're going to skip ahead to section C11, which would be the lower abdominal strains. The guidelines here indicate that this is more of an occupational problem where there's heavy lifting involved. Medical providers need to be aware that where there's a lower abdominal strain, this could also be symptoms from a hernia, and that should be very carefully evaluated. Again, the usual treatments again are approved out of hot and cold therapy and physical therapy. And medications again are the
Usual suspects.
The usual suspects. And Neil, did you have any additional comments on this?
You know, the lower abdominal strain, it doesn't indicate again in the medication section that opioids are not recommended. So I'm guessing that doctors just would never prescribe it for this type of condition. I have seen, in my practice, I've seen hernias pretty, I'd say not common, but common enough that they're memorable. So it's good that the board has come out with medical treatment guidelines for that condition.
And I think it's interesting that the board is acknowledging that these kind of groin strains are worthy of evaluation and need to be addressed by medical treatment guidelines. They can be debilitating, and they do need treatment. It's not it's not a hip fracture, but it is a work-related injury, and it does require treatment and medications, possibly surgery. Okay, Neil, that is as far as I was going to take it. I did not discuss section C12 today.
Okay, well, C12 is just brief, and it is with epididymocrisis, but the diagnosis is epididymitis, which is an inflammation of the epididymitis, which is part of the testicles. And people who report a history of heavy lift or strain that precipitated the symptoms give rise to the possibility that there is epididymitis. Standard medications are used to treat, which is actually the only treatment. However, the notes indicate that a clinical course that does not resolve should be evaluated by a urologist. So those kind of, I think they go a little hand in hand talking about the heavy lifting and that it could cause the epididymitis. But basically it goes away with treatment with NSAIDs, and if it doesn't, you should be evaluated by a urologist.
Okay, thank you, Neil. And now we'll open it up if anyone has any questions.
Well, we have a question from the chat from Brian Prince to everyone, which I'm hoping Brian Prince can answer. Question for the end regarding the MRI as the gold standard for osteoarthrosis. If a doctor performs an imaging study otherwise consistent with the MTGs, but it isn't an MRI or X-ray, and doesn't explain why, do you think the bill would be vulnerable to a C8.1 Part B?
Sounds like a typical Brian question.
I'd like to hear what Brian's thoughts are on the matter.
Well, I for one think it will be.
I think you're right.
Seeing as how they're indicating, with their highlighting a specific test as the gold standard, I think their way of saying, you do this unless, and if you don't explain unless, it's just like everything else. You don't prove it, you don't get it.
I think you're right, Brian. I think you'd need a variance. I think the doctor would probably take great umbrage at being challenged on why they're recommending or doing one test as opposed to another test. And that would make them vulnerable to making mistakes during their testimony with respect to getting the treatment that they're requesting authorized. But I think these guidelines, like all the other guidelines that we've come to use in requiring doctors to provide what the board finds as reasonable treatment, will provide us with great ammunition for resisting treatment, which strays outside the letter of the four corners of the guidelines.
Well, I wouldn't go as far as to say they would need a variance if they provided, at least a halfway decent explanation of it. He has a bullet in his hip, we can't do an MRI, then, that I think, in my opinion, should suffice in terms of why they're doing a CT or something else. But I think if they just go ahead and do it and don't explain, I think it makes them vulnerable.
Right. I mean, well, just like any other proposed treatment, I mean, if the doctor can provide an explanation for why it is that they're not using the treatment recommended by the guidelines, it would be foolish, I think, for a carrier or an employer to take a position that's unreasonable just for resisting the treatment as not being within the four corners of the document, for when with an example like what you're proposing.
Also, just briefly on the subject of osteoarthrosis, the medical treatment guidelines do indicate that following a traumatic injury, it can take years before that develops. It can take a long time for osteoarthrosis to set in. And so we might be doing diagnostic studies, several years after a traumatic injury. I thought that was interesting.
Yeah, good point. I'm going to actually unmute everyone because we may have had people who wanted to ask questions verbally. We did entertain that question from Brian from the chat function. So I'm going to unmute everybody. If you've been taking calls or doing other things during the presentation, I would request that you mute yourself again so that everybody can hear any questions that people may want to ask verbally.
I just have one. How many times do you get to work and take umbrage against something in normal conversation on a daily basis, Melissa?
I find that daily I find something to which I take great
umbrage.
Tomorrow's SAT word will be specious. Is Mark J on the call? We can always count on Mark J for giving us a good question.
Hello, Mark.
I guess he's not with us today. Okay, well, if nobody has any other questions, these guidelines, I'm sure you guys covered this, go into effect on January 1st of 2021, correct?
That is correct.
All right, excellent.
That's the day.
Wonderful. And next month, we will be regaled, hopefully without great umbrage, at the presentation from another one of the excellent LOMAD attorneys. I am not sure who's up next, but if you just follow along in the letterhead, you will know who is going to be presenting our next series of the new medical treatment guidelines that the board has promulgated, which will be effective on January 1st of 2021. We will, as we always do, send out an invitation for everybody. And we do record these webinars as well. And I managed to get through the technology to make that happen today, I believe successfully. And we appreciate your patience as always as we put on these presentations. And we're very grateful that y'all tune in. So thank you very much to Paul and to Neil for guiding us through today's medical treatment guidelines. And we will see everybody next month. Take care, everyone.
Thanks, Paul.
Stay healthy. Take care, everybody.
Thank you. You too.
Bye.